1. What is the cardiac cycle? The cardiac cycle represents one complete heartbeat and consists of two main phases, systole and diastole. During systole, the heart contracts to pump blood. During diastole, the heart relaxes to allow blood to fill its chambers. 2. How does the heart know when to contract and relax? The heart is a remarkable organ that functions as a muscular pump to circulate blood throughout the body. Its ability to contract and relax in a coordinated manner is regulated by a specialized electrical conduction system and a series of feedback mechanisms. Here's how the heart knows when to contract and relax. 1. Sinoatrial SA node. The process begins with the sinoatrial SA node, often called the natural pacemaker of the heart. The SA node is a cluster of specialized cells located in the right atrium. It generates electrical impulses spontaneously, which initiate each heartbeat. 2. Electrical conduction. The electrical impulses generated by the SA node travel through the atria, causing them to contract and push blood into the ventricles. This coordinated electrical conduction ensures that the atria contract before the ventricles. 3. Atrioventricular AV node. The electrical signal then reaches the atrioventricular AV node, another specialized cell cluster between the atria and ventricles. The AV node acts as a delay or relay station, briefly slowing down the electrical impulse to allow the ventricles time to fill with blood from the atria. 4. Bundle of His and Purkinje fibers. After passing through the AV node, the electrical impulse travels down the bundle of His, and then branches into smaller Purkinje fibers that spread throughout the ventricles. This rapid transmission ensures a coordinated contraction of the ventricles from the bottom up, forcing blood into the arteries. 5. Myocardial contraction. As the electrical impulse travels through the ventricles, it triggers the contraction of the heart muscle cells, myocardium. This contraction forces blood out of the heart and into the circulation. 6. Relaxation. Once the electrical impulse has passed through the heart and the contraction is complete, the heart begins to relax. This relaxation allows the chambers, atria and ventricles, to fill with blood again in preparation for the next cycle. 7. Autonomic nervous system. The rate and force of heart contractions can be modulated by the autonomic nervous system. The sympathetic nervous system can increase heart rate and contractility in response to stress or exercise, while the parasympathetic nervous system can slow down the heart rate during periods of rest and relaxation. 3. What is preload and afterload? Preload and afterload are two important concepts in cardiac physiology that describe the factors influencing the workload and function of the heart. They play a critical role in determining cardiac output and the heart's ability to pump blood effectively. Preload. Preload refers to the initial stretching or tension of the cardiac muscle fibers, myocardium, just before the heart contracts during ventricular systole, the phase of the cardiac cycle when the ventricles contract to eject blood into the arteries. It is primarily influenced by the volume of blood returning to the heart from the venous circulation, venous return. The greater the volume of blood returning to the heart, the greater the preload. Preload is often described using terms like end diastolic volume, EDV, or end diastolic pressure, EDP, which represent the volume or pressure in the ventricles at the end of diastole, when the ventricles are relaxed and filling with blood. An increase in preload typically results in increased myocardial stretch, which, up to a certain point, leads to a more forceful contraction, Frank-Starling mechanism. This helps the heart pump out the increased volume of blood efficiently. However, if preload becomes excessive, it can lead to problems such as heart failure, as the heart may struggle to handle the increased workload. Afterload. Afterload refers to the resistance that the ventricles must overcome to eject blood into the systemic circulation, for the left ventricle, or the pulmonary circulation, for the right ventricle. It is primarily determined by peripheral vascular resistance, which is the resistance to blood flow in the arteries and arterioles throughout the body. Afterload can also be influenced by the pressure in the aorta, for the left ventricle, or the pulmonary artery, for the right ventricle. An increase in afterload makes it more difficult for the heart to eject blood because it must generate a higher pressure to overcome the resistance. Conditions such as hypertension, high blood pressure, can significantly increase afterload and make it more challenging for the heart to pump effectively. In summary, Preload and afterload are critical factors that impact the function of the heart. Preload relates to the volume of blood in the heart's chambers before contraction and is influenced by venous return, while afterload refers to the resistance the heart faces when ejecting blood into circulation and is influenced by vascular resistance and arterial pressures. Maintaining an appropriate balance between preload and afterload is essential for the heart to pump blood efficiently and meet the body's metabolic demands. Dysregulation of these factors can lead to cardiovascular disorders and conditions. 4. What is compliance and contractility? Compliance and contractility are two important concepts in cardiac physiology that describe the properties of the heart muscle and its ability to pump blood effectively. These concepts are crucial in understanding how the heart functions as a pump within the circulatory system. Compliance. Compliance refers to the ability of a structure to stretch and expand in response to a change in pressure or volume. In the context of the heart, cardiac compliance specifically refers to the ability of the heart muscle, myocardium, to stretch and accommodate the incoming blood volume during diastole, the relaxation phase of the cardiac cycle. A compliant heart is one that can effectively fill with blood when the atria relax and allow venous return. It is often associated with healthy, elastic myocardium. Reduced cardiac compliance can occur due to conditions such as myocardial fibrosis, cardiomyopathies, or aging, making it more challenging for the heart to fill adequately during diastole. This can lead to impaired cardiac function and decreased stroke volume. Contractility. Contractility refers to the inherent ability of cardiac muscle cells to contract when stimulated by an electrical impulse. It is a measure of the strength and force with which the heart muscle contracts during systole, the contraction phase of the cardiac cycle. Contractility is influenced by factors such as the concentration of calcium ions inside the muscle cells, the responsiveness of the contractile proteins, actin and myosin, to calcium, and the efficiency of the cellular energy supply, for example, ATP, for contraction. Positive inotropic agents, such as hormones, for example, epinephrine, and medications, for example, digitalis, can increase contractility and make the heart contract more forcefully, resulting in a higher ejection fraction and stroke volume. Negative inotropic agents, on the other hand, decrease contractility and reduce the force of cardiac contractions. Some drugs, like beta blockers, have a negative inotropic effect and are used to treat conditions like hypertension and heart failure. In summary, compliance and contractility are both essential aspects of cardiac function. Compliance relates to the heart's ability to stretch and accommodate incoming blood during diastole, allowing for efficient filling, while contractility pertains to the strength and force with which the heart muscle contracts during systole, enabling it to pump blood effectively. These properties are regulated by various factors and can have a significant impact on overall cardiac performance and circulation. 5. What are ejection fraction and stroke volume? Ejection fraction, F, and stroke volume, SV, are two important measures of cardiac function that provide information about the heart's ability to pump blood effectively. Ejection fraction, F. Ejection fraction is a percentage that represents the fraction of blood pumped out of the left ventricle during each heartbeat, systole, compared to the total volume of blood in the ventricle at the end of diastole, when the ventricle is fully relaxed and filled. F is a key indicator of the heart's contractility and pumping efficiency. It is commonly used to assess cardiac function and diagnose various heart conditions, including heart failure. The formula for calculating ejection fraction is F % equals SV/EDV times 100, where SV, stroke volume, is the amount of blood ejected from the left ventricle during systole. EDV, end diastolic volume, is the volume of blood in the left ventricle at the end of diastole, just before systole begins. A normal F typically falls within the range of 55% to 70%. A lower F indicates reduced pumping efficiency and may be indicative of heart dysfunction or cardiomyopathy. Stroke volume, SV. Stroke volume refers to the volume of blood ejected by the left ventricle during each heartbeat, specifically during systole. It represents the amount of blood pumped out of the ventricle into the systemic circulation. SV is an essential determinant of cardiac output, which is the volume of blood pumped by the heart per minute. Cardiac output, CO, is calculated as CO, L per minute, equals SV, milliliter/beat, times heart rate, beats per minute. Stroke volume can be influenced by factors such as preload, the volume of blood in the ventricle before contraction, contractility, the strength of ventricular contraction, and afterload, the resistance the ventricle must overcome to eject blood into the arteries. An increase in stroke volume can result from factors such as increased venous return, preload, or enhanced contractility. Conversely, conditions that reduce stroke volume can include decreased contractility or increased afterload. Both ejection fraction and stroke volume are essential parameters for assessing cardiac function and diagnosing heart conditions. They provide valuable information about the heart's ability to pump blood and adapt to changing hemodynamic demands. A comprehensive evaluation of these parameters, along with other clinical assessments, helps healthcare professionals understand and manage heart health. 6. Why cardiac output is important, and what are the causes for decreased and increased cardiac output? Cardiac output, CO, is a critical physiological parameter that measures the volume of blood pumped by the heart per minute. It is an essential determinant of overall cardiovascular health and plays a pivotal role in maintaining tissue perfusion, oxygen delivery, and metabolic homeostasis throughout the body. Here's why cardiac output is important. Tissue perfusion. Cardiac output ensures that blood is continuously circulated to all tissues and organs in the body. Adequate blood flow is essential to provide oxygen and nutrients and remove waste products from cells. Oxygen delivery. CO is directly related to the amount of oxygen delivered to tissues. If CO decreases, tissues may not receive enough oxygen, leading to hypoxia, oxygen deficiency, which can damage organs and impair their function. Metabolic demands. CO can adjust to meet the body's changing metabolic needs. During exercise or stress, the body requires more oxygen and nutrients, so CO increases to meet these demands. Conversely, Colorado decreases during periods of rest and relaxation. Blood pressure regulation. CO influences blood pressure. It is one component of the equation that determines blood pressure, with blood pressure being the product of CO and peripheral vascular resistance, the resistance to blood flow in the arteries. Changes in CO can affect blood pressure. Now, let's explore the causes of both decreased and increased cardiac output. Causes of decreased cardiac output. Heart failure. Heart failure occurs when the heart is unable to pump blood effectively, leading to reduced CO. It can result from various underlying conditions, including coronary artery disease, cardiomyopathy, or heart valve disorders. Myocardial infarction. A heart attack, myocardial infarction, can damage the heart muscle and impair its ability to contract effectively, leading to decreased CO. Arrhythmias. Abnormal heart rhythms. Arrhythmias can disrupt the coordinated contractions of the heart chambers, leading to inefficient pumping and reduced CO. Valve disorders. Conditions such as aortic stenosis, narrowing of the aortic valve, or mitral regurgitation, leakage of the mitral valve, can impair the heart's ability to eject blood, reducing CO. Pulmonary embolism. A blood clot in the pulmonary arteries can obstruct blood flow to the lungs, increasing pulmonary vascular resistance and reducing right ventricular output, which can subsequently decrease overall CO. Causes of increased cardiac output. Exercise. Physical activity and exercise increase the body's metabolic demands, leading to a temporary increase in CO to deliver more oxygen and nutrients to working muscles. Fever. Elevated body temperature, such as during a fever, can increase metabolic demands, leading to an increase in CO to support the body's increased energy requirements. Hyperthyroidism. An overactive thyroid gland, hyperthyroidism, can stimulate the heart to beat faster and more forcefully, leading to an increase in CO. Anemia. Anemia, a condition characterized by a low red blood cell count, can lead to increased CO as the heart compensates by pumping more blood to maintain oxygen delivery to tissues. Pregnancy. During pregnancy, CO increases to meet the demands of the growing fetus and increased blood volume. Both decreased and increased cardiac output can have significant clinical implications, and healthcare professionals monitor and manage CO to ensure adequate tissue perfusion and overall cardiovascular health. Treatment for conditions that affect CO may include medications, lifestyle modifications, and, in some cases, surgical interventions.